Yes, sir.
Ladies and gentlemen, welcome again to another episode of Thoughtful Tuesday IAPS Webinars. This is a series of webinars that have been going on now for several months, and the focus essentially has been to involve predominantly youngsters and people who are doing stuff that is, worthy of emulating teaching, and also allow time for the discussion to happen, for the presentation to happen uh, in a more relaxed manner, without a push of 20 minutes chalo khatam karo, that kind of an environment. So we have had assorted topics being discussed over the several months. We had a break in May for to coincide with the summer vacation, and we are back now in June. So today is the first of the post vacation, first one in June. So I take great pleasure in inviting Dr. Vikesh Agarwal, who is we have a department at Netaji Subhash Chandra Bose Government Medical College in Jabalpur. Vikesh is well known to all of us. He has an abiding interest in minimal access surgery and regularly speaks about it, puts up videos, and has ventured into many areas such as stealth and regular use of this thing in anorectal malformations. So he's somebody that we keenly watch, and I'm sure what he's going to talk today would be of great interest. So Vikesh will talk about anorectal malformation and the management algorithm in the era of minimal access surgery. Vikesh, over to you.
Thank you, sir. At the outset, I would like to thank the team of Indian Association of Pediatric Surgeons for inviting me to get involved in this particular talk, Thoughtful Tuesday. And as the theme mentions, it is a Thoughtful Tuesday. So my topic is a little, it is deviating from the normal sort of topics we have during webinars. And it is a little thought-provoking thing based on our experience of management of anorectal malformation, especially with reference to minimal access surgery. So we all know the gold standard surgical care for anorectal malformation has been posterior sagittal anorectoplasty, as developed and propagated and adopted widely by everyone, as proposed by Professor Pina. But approximately like around in this beginning of this new millennium, laparoscopy entered in the management of anorectal malformation, and it offered certain advantages over posterior sagittal anorectoplasty, which led it to become a widely adopted mode of care in management of anorectal malformation. So high anorectal malformation, especially, they are good cases for laparoscopic anorectoplasty involving rectovesical fistula, rectobladder neck fistula, or a rectoprostatic fistula. So, am I connected? I can't see.
Yes, we can. You're online, Vikesh. We can hear you, okay. And your slides are visible.
So the biggest advantage of laparoscopic anorectoplasty is avoidance of a posterior sagittal muscle cutting incision. And as there is higher magnification associated with minimal access surgery, that simplifies or eases the fistula dissection, which is very close to the vas and the seminal vesicles ending at the level of the fistula, as we know in cases of anorectal malformation. Obviously, there is, as a result, early recovery. And in last 20 years, with various randomized control trials and systematic review and meta-analysis, have proven beyond doubt that it offers comparable function vis-a-vis open posterior sagittal anorectoplasty. Obviously, there is a cosmetic advantage also. There is no abdominal scar. So this is, I won't go into much details of the technique, as many of you know about that, but this is a case of rectoprostatic urethral fistula. So usually it's a 3-port technique. And the first step is the dissection of the mesocolon, and you mobilize the colon on both the sides, create a window behind the rectum. And this is the left side of the dissection you see on the video. So usually for a right-handed person, left side dissection is a little tricky. The key points is to identify the ureter vas difference and avoid the injury to the rectum and maintaining the vascularity of the rectum. is a posterior dissection, which is crucial because a good posterior dissection allows you to easily identify the fistula. That you can see the fistula is being divided with the scissors, and the narrowed portion of the rectum gives you a clue that the fistula is ending here. And if it is a wide mouth fistula, then you can suture close it. If it's a narrow mouth fistula, then you need not suture close it. And usually in most of the cases, like 60-70% of the cases, we don't close it. And another advantage of the laparoscopy is you identify the levators very well. And there are few stimulators also available, although we are not using them very often. But the identification of the levator and staying exactly in the midline is another advantage of the laparoscopic anorectoplasty. And after creating a tunnel, then you do the pull through like you do. And external part I have not shown here. It is just similar to what we do in open surgery. So this is another case where there was a rectovaginal fistula, and this is a normal 3-port surgery. And usually the communication, it is there in the vagina, like in a rectovaginal fistula, which is supposed to be a rare malformation, but in our region we often get rectovaginal fistula. And all cloacae, and there is a recent concept that cloaca undergo stage reconstruction, like anorectoplasty is done in infancy, and nowadays reconstruction of the vagina and the common channel, everything goes in a later date around adolescence. So initially we used to do PSA RVUP, but with the advent of laparoscopy, we have started doing just laparoscopic anorectoplasty in such cases and defer the vaginal reconstruction at a later date. So this is just a typical example of female anorectal malformation. Again, in this case, I suture close it. There is one study from Japan who they do a cystoscopy of the fistula. They put a scope in the fistula and identify the caliber to find out that a closure is needed or not. Recently, like 4 years back, we got a 3D laparoscopy also with us. So many cases nowadays we do with the 3D laparoscopy. The biggest advantage is very good image quality, even better than the high definition system which we are using nowadays of the Karl stores. And a lot of depth perception is there. So as this is a perineal surgery involving in a very small pelvis, so advantage of 3D laparoscopy comes into play in this particular surgery. And as you can see in this video, there is a median sacral vessel seen behind, and a dissection of the mesocolon is being done. One more important thing which we have changed recently is nowadays we are using harmonic, but you can do this surgery with the monopolar usual cautery. There is no problem with that. So certain technical advantages have eased our life. And as you can see, a lot of lymphatics and everything you can see very clearly with the 3D laparoscopy, which you are usually not able to appreciate in the conventional high definition surgery. It has additional advantage, like if it's a rectobulbar fistula and you are doing it laparoscopically, then the depth perception comes into play, and it's a good modality or technological innovation to adopt in especially urological surgeries, bladder reimplantations, and pelvic surgeries, esophageal surgeries. So as you can see in this video, the dissection of the fistula is gradually completed, and it is identified. The dissection is complete, is indicated by identifying the narrowing of the fistula. So once the fistula narrows down, then you divide the fistula, and here you can see seminal vesicles. I don't know which device you're using, but if it's on a laptop, then you can appreciate the seminal vesicles and ending of the vas deferens at the site of the fistula, and you divide the fistula just above it. And as you can see, here the fistula is not very wide. So in this case, we didn't close it and we just divided, keep catheter for 2 or 3 days. And after 3 days, we discharge the patient. Rest of the procedure remains same. This study we published, which shows that there is better image quality identification. Surgeon's physical strain is reduced. Not too much of advantage, but it's a new technology, and PG should be exposed to that. So now coming to another, like we have been doing this surgery, laparoscopic anorectoplasty, since 2009. So over this much period, we have experienced certain challenges associated with staged laparoscopic anorectoplasty. I'm calling it stage because I will be talking about one stage LARP also without a colostomy in my talk later on. So the first thing which we encountered is the port ergonomics, because there is usually a colostomy in the left iliac fossa, and it hampers the port ergonomics. And if you put a port in the umbilicus for optical vision, then you have to put both the ports, working ports, on the right side, or you have to ascend the optical port in the epigastrium. Second thing which we encountered, like we experienced in many of our cases in initial phases, is the rectal stenosis, not the anal stenosis. Anal stenosis depends upon the vascularity of the rectum, which is, if it is good, there is no anal stenosis. But rectal stenosis at the level of the uh, levator, where the rectum is entering or exiting outside the pelvis, if that hiatus is narrow, that results in rectal stenosis. This is one very important observation we had in our experience. And third is like management of rectobulbar fistula. Usually prefer, if we identify a rectobulbar fistula, that is intermediate type of anorectal malformation, we go for PSARP. But if you end up like doing laparoscopy, then it becomes little difficult to dissect the fistula such low down. Recently, we have started using 3D, then it becomes a little easier. Fourth problem which we encounter very often is mucosal prolapse. And fifth problem, especially when postgraduates in the beginning of their career, they do a colostomy, then there is a short distal limb. So one by one, I will uh, cover how to manage these problems. Slide is not moving. Let's wait for a second. Yes. So first thing which we overcome by with this port ergonomic problem. So if you see, look at this figure. On the right side, you see the figure where the left iliac fossa colostomy is there. So you see the triangulation concept is not achieved, and that baseball diamond concept is not achieved. So what we have done is like we have lateralized the stoma. So when we do colostomy, we don't keep patient in supine position. We keep in the lateral position and do a colostomy laterally in the flank. So that gives us whole abdomen free of any scar or any colostomy, and that allows us to put an umbilical port for optical vision, and two working ports very easily in both the para-umbilical region, and that doesn't compromise with the baseball diamond concept. So this lateralization of the colostomy, this study we validated by measuring various angles like manipulation angle, elevation angle, azimuth angle, and we published our data to document that this definitely improves the port ergonomics in laparoscopic anorectoplasty. Second thing which I was talking about was rectal stenosis. As you see in this picture, there's a stenosis developing in the lower part of the rectum at the level where pubo rectalis is there or levator is there. So this stenosis, usually when we used to create the tunnel, we used to use port, and gradually we switched over to dilators. And dilator up to 12 number dilator was the maximum dilatation which we used to do. But as we encountered few cases where there was rectal stenosis because of narrow hiatus, now we have adopted a policy that we use a two-finger dilatation. So after dilating up to 12 number dilator, then we put two fingers, so at least two-finger dilatation, two index fingers are put inside. Slight stretching of the levator is done, and that avoids this complication, which we found very common in our early experience. This is one case which I did laparoscopic anorectoplasty for a rectobulbar fistula around about 2011 or 12. And we had when we retrospectively reviewed the video, then not much of stump was left. But later on, patient developed with a big diverticulum, which was connected with the bladder, and it was residual stump which enlarged gradually in size. So that made us think a lot about that, and we became very careful in selecting cases for LARP. If it is a rectobulbar fistula, then we go for a limited PSARP. But if by any chance we put in a laparoscope in a case of rectobulbar fistula, then we basically combine LARP with the PSARP. So I will tell you this one very good concept I learned from Professor Nguyen Lin, who is one of very famous laparoscopic surgeon in Asia, who works mainly on neonatal surgery and has large experience in anorectal malformation. So we take the advantage of laparoscopy by mobilizing the rectum, while the fistular dissection and this thing is done with the posterior sagittal approach, and there is excellent exposure and access to fistula. This is something similar to what we do in Stephen's technique, where there is not a complete PSARP. So I will show you one video also. Another advantage is that puborectalis is not cut in this particular procedure. So you retain the puborectalis and you tunnel the rectum behind the puborectalis. So your incision is just below the coccyx, a small incision, 2 centimeter incision. Rest of the incision is only skin incision. And this is called as modified laparoscopic anorectoplasty. So this is one video demonstrating procedure for a rectobulbar fistula. Abdominal part is similar to what we do routinely for other cases. This is a mobilization of the rectum, and a bladder stitch assists you or helps you to give good exposure for the fistula. Usually it's not required in a rectoprostatic fistula, but in a bulbar fistula or a low rectoprostatic fistula, you have to take the bladder stitch. So this you can see rectum is mobilized, but just up to the level of seminal vesicles, and whole of the pelvic portion of the rectum is mobilized. This is the identification of the levator, you can see. But now we switch over, like change the position of the patient and keep in the prone position like PSARP position. And this is the incision which is involved. As you see, just below the coccyx is a complete incision dividing the pubococcygeal raphe, and midline incision is opened and rectum is identified, taken with the space suture, which is already mobilized. So now you can hook the rectum very easily and sling the rectum. And now fistular dissection is done from this particular incision only, without dividing the puborectalis. Under vision, you can close the fistula, and that you are very sure that there is not even a 1 centimeter stump is left, because that 1 centimeter stump can later on become such a big diverticulum, which I showed in my particular case. After that, then you tunnel the rectum below the puborectalis. You will see very good demonstration of the puborectalis contraction, and this has excellent sphincter function postoperatively. And as you can see, there is encircling sphincter, which is not divided like in complete PSARP. So this modification we published in our own Journal of Indian Association of Pediatric Surgeons. And this provides another advantages of cosmetic advantage, because nowadays we have stopped taking skin incision also at that level. Next problem which we encountered initially in our study was rectal prolapse, because we used to be like very skeptical, good mobilization is required, and we used to mobilize the rectum quite a lot, and that used to result in rectal prolapse, usually associated with high anorectal malformation. And usually these patients have poor strength of musculature, at times they have sacral defect, and excessive mobilization, as I said, is an important cause for this. It is in LARP, it is more as compared to PSAR. So the solution which we got for this particular problem is just adequate mobilization. Not too much of mobilization is required in the rectum. Once you pull the rectum down, and if you find it inadequate, you can add a little more mobilization by again going in the laparoscopic part, and proper rectal fixation to the external anal sphincter. And the rest of the redundant rectum should be excised during anoplasty. Yes, sir?
Yes, sir.
Okay. So
Vikesh, it's echoing. It's echoing on somebody else's device. Please go ahead. Please go ahead.
Fixation to levator has been offered by few people, but we haven't found it advantageous, because if you have like mobilized the rectum too much, then it is bound to prolapse. With this intervention, just adequate mobilization concept, we have been able to reduce our mucosal prolapse up to 4% in recent experience of 5 years. Another problem which I mentioned before is short distal limb. In such cases, we we ask our postgraduates or our young pediatric surgeons to be very, very careful in raising the colostomy, and it should be confirmed twice or thrice that you are doing a high sigmoid colostomy and not a mid sigmoid or a low sigmoid colostomy. If it happens, then in that case, usually you have to bring down the colostomy. At times we switch over the colostomy to another side a little bit inferiorly, or we bring it down completely and do a PSAR, pull through. Another problem which we encounter in our region, especially apart from pouch colon, is rectal ectasia, because pouch colon cases we don't handle laparoscopically, but normal dilated rectum is a very frequent finding, especially those cases which have turned up late after colostomy, like 2 years, 3 years, there is a large fecolith inside. So this should be this can be avoided by doing an early pull through. And if really there is a rectal ectasia, then it is always preferable that after division of the fistula, you take that colon out through the umbilical incision and excise the dilated rectum, because that is going to give a very poor function in terms of continence and soil constipation later on if you retain that rectum. One very interesting concept we have been working upon is the learning curve for various surgeries. And one very good mathematical way of measuring how many cases do you need to learn a particular procedure in laparoscopy is the Q-sum chart. So this we created this for youngsters' interest, that you need like about, this a very simple procedure. So you need about 19 cases to learn the procedure, and proficiency is achieved in 27 cases. This Q-sum chart is a typical mathematical chart where this point is where learning has reached, and when there is a plateau, then this is the point where proficiency has reached. So this is one very good way of calculating, a very objective way of calculating how easy or difficult this particular procedure is. And you can compare your learning with learning of various other people by using various modes of learning curve. Sometime I will speak on that also. It's very interesting concept. Now coming to my second part of the talk, as we have seen in our setup, most of the patients, when they go for colostomy, few of them don't turn up. When we did a study long back in last decade, we found that about 18 to 20% patients were dying because of colostomy diarrhea. So that made us think about starting one stage anorectoplasty. We started doing open anorectoplasty, PSARP. It is good for rectobulbar fistula, but for rectoprostatic fistula, it becomes a little difficult because rectum is high up and dissection becomes very difficult from perineum in a dilated rectum. So the advantage of one stage anorectoplasty, we all know that surgery is in one go, and the biggest advantage is brain defecation reflex, which gets initiated right at birth. And there is no morbidity of colostomy. As I mentioned, mortality of 18% due to not colostomy mortality inside hospital. After patient has gone home, lot of colostomy diarrhea is there, patient fails to thrive. This is a study we conducted between 2007 and 10. We found that mortality was up to 18%, and that was a big alarming figure we came across. So that made us think or develop techniques to do one stage anorectoplasty avoiding a colostomy. There is no abdominal scar and there is no perineal division. If we adopt laparoscopic approach for anorectoplasty, obviously there is reduced perineal infection because you are doing a anorectoplasty with which a stool is coming out and there is a midline scar in the PSARP approach, which leads to very commonly perineal infection, which can be very disastrous in cases of anorectal malformation. And obviously there is reduced psychological burden on the parents, and financial burden is reduced. When we thought of doing laparoscopic anorectoplasty for anorectal malformation, there were few challenges. First thing is like the distension. There is no space in the abdomen to work upon. And second, the meconium is usually very thick. Initially, like in 2009-10, I remember I used to put in 16 French Venflon per abdomen and aspirate the meconium. But that was very thick. It is not possible to do that. So we deferred that for a long period of time. But and the third thing which we come across very commonly is the sepsis. So when we put in a laparoscope, we find the colon is having patches over it, and it's not a good case for one-stage anorectoplasty. So colostomy is the best option for that. To overcome all these problems, if you see this article by Diao, so he is the one who first time published his experience of one-stage anorectoplasty in 2016, where what he did is taking out the sigmoid colon through the umbilical incision and deflating the colon completely with a colotomy, repairing the colotomy, and then putting it inside, which I think was too much or too ambitious or too enthusiastic, because that is colotomy incision is predisposed to a leak also. So that idea was not appealing. But what we learned, like I remember my Professor Rena, in very old days when I was MS postgraduate, at times like patient is very bad, very sick, and not having good saturation, not able to withstand surgery. So in emergency night, he used to come and he used to put a perineal intragas and deflate the colon. By morning, patient used to stabilize and then we go for the colostomy. So that idea clicked in our mind, and we devised this approach which is called as transperineal intracath meconiolysis and evacuation technique, time technique, where we put in a 16 gauge cannula through perineum into the colon. And as this colon is massively dilated and bulging down like anything, so at times you can feel that bulge in the perineum when the patient comes to you when he cries. So that goes straight away into the rectum, and you can deflate the colon completely. You can give washes. At times we have used an acetylcysteine also for that. And this is one video demonstrating how it works. So this you can see is a severely dilated colon. Otherwise, a laparoscopy won't be feasible in such a case. We do a laparoscopy and rule out there is NEC. There are no patches in the colon. Colon looks healthy. Small bowel looks healthy. So as you see, with this distension, it is not possible to do a laparoscopic procedure. So this is the transperineal approach, time approach, with which the intracath is put inside the rectum. As such, we don't use guidance, but we have in few cases use ultrasound, but it is usually not needed because rectum is so dilated and bulging low down that intracath straight away goes into the rectum in one go. And this you can see whole of the air is aspirated, and you can put some saline and acetylcysteine, deflate the colon completely, give a patient wash for about this intracath is seen at the level of the fistula entering into the rectum. So this you can see there is not any spillage of the meconium into the abdominal cavity because you have already deflated everything. So you have to give a 10 minutes patient wash, and as the contents move down gradually, you can put some pressure in the in the right iliac fossa, in the upper abdomen to move the content lower down, and pull through is made feasible. Then there were certain cases when we started doing time approach that they were not suitable also for primary pull-through or one-stage laparoscopic anorectoplasty or SLAR, because they were having a lot of infection in the bowel. But still our desire, like to do one-stage laparoscopic anorectoplasty didn't reduce. And what we started doing is not doing a colostomy, but doing a cecostomy, temporary cecostomy. We call it blowhole cecostomy. Not a proper colostomy, which is not sutured and everted outside. It's just venting cecostomy. So that deflates whole of the colon. And in another 4 or 5 days, we do a contrast study, ascertain the level of the fistula. Like in this particular case, you can see a rectovesical fistula, and go for a delayed primary pull-through in the same admission after 6-7 days. By that time, all the infection is settled, abdomen is totally deflated, babies have started taking fluids also. And these stomas usually, like in 80% of the cases, is close on their own. It is well mentioned in literature, blowhole cecostomy. Almost 80 years back, this procedure was devised. And in 80% of the cases, it doesn't require a surgical closure. This is one case where a delayed primary pull-through has been done. As you can see, I am putting my working port by telescoping technique because in the right iliac fossa, there is a cecostomy, a blowhole cecostomy. So normally I don't put ports, I put instruments directly. This is the cecostomy you can see. hanging on the abdominal wall. And by the side of the cecostomy on the right side, you put your instruments, and rest of the surgical procedure is same as you do in any LAR. So it is a delayed primary stage approach which increases patient safety. You can get rid of the infection which was causing the trouble, and giving the advantage of earliest passage of the stool through the anus to the patient. So this, you see, it is appearing just like any stage laparoscopic pull through, but this is just 6 or 7 days after a cecostomy in the same admission. So this is the idea which we recently adopted in the last 2 years. This is one case. You can see the picture. There is no surgical closure being done here, and it has closed completely. After few months, like 4-5 months, you see only a small scar there. There are a large group of patients which present to us a female anorectal malformation, which are not vestibular fistula, or they are cloaca or rectovaginal fistula, and they're deflating well. This is something which is not very evident in literature, but there are a huge number of patients coming to us who deflate well, so they don't have distension. Even in cloaca, we adopt time technique of OSLAR, but those who are deflating well are good cases for laparoscopic pull-through, and obviously they should avoid a colostomy because they are like any, it's almost like Hirschsprung's disease, where we don't do a colostomy, we do a pull-through after giving rectal washes. So overall, our experience of one OSLARP is of almost 4.5-5 years now, and it provides this time technique or blowhole cecostomy approach. It provides very satisfactory decompression. Early LARP becomes feasible, and brain defecation, as I said, brain defecation reflex gets initiated right at birth. There are real advantage of that toilet training becomes very good in such patients. Spontaneous closure of cecostomy is there in majority, and obviously there is reduced psychological and financial burden because you're avoiding a colostomy. And comparable continence is there. We don't have a very long-term follow-up for these patients, but 4-year follow-up is there. And there are many patients who have crossed 3 years and they are able to tell, and now we are able to assess the continence better. This data is already published in Journal of Laparoscopic and Advanced Surgical Technique. On the basis of this experience, I haven't touched the areas like pouch colon, vaginoplasty, cloacal malformation, because that is in itself is a different topic. Based on this particular experience and these modifications which we have done over a period of time, we have made a new algorithm which is slightly deviated from the normal algorithm we follow for anorectal malformation. Like in male patients, if it is intermediate variety, you are able to identify on cross-table chronogram. And if there is no sepsis, we still go for limited PSARP in such cases. But if the baby is sick, we go for a blowhole cecostomy and a neonatal PSARP after 6-7 days. No need of laparoscopic pull-through. And there are certain patients, still we have not given up with the colostomy. So we do a lateralized colostomy, as I said, not a left iliac fossa colostomy. In high anorectal malformation, if there is no sepsis on laparoscopy, there is no NEC, we straight away go for OSLAR, that is using time technique. But if the baby is sick, then we go for blowhole cecostomy, a delayed primary pull-through, and still there is a large group of patients where we go for traditional approach of colostomy and LAR. In vestibular fistula, we all know it is one stage pull-through. And in cloaca, if it is deflating, like I mentioned, we get very often cloaca who are deflating. We go for OSLARP approach. And if it is there is no sepsis, then we go for, and there is distension, like there is an obstructed cloaca where there is distension. Then again, either of the two, like time technique or a blowhole cecostomy and a delayed PSARP, depending on the bowel condition or patient condition, you can decide. And obviously, lateral colostomy followed by stage pull-through is a handy procedure and safest procedure if that expertise is not available that particular day. Pouch colon, we don't handle laparoscopically, we do with the standard approach. And this is our data of between 2013 and 2023. 840 cases of anorectal mal, because this is one of the most common anomaly we encounter in government setup. This anomaly is not seen very frequently nowadays in private setup, but in government it's still a very common problem. And we have reduced almost like 35% of colostomy adopting this algorithm. And as you can see in male anorectal malformation, intermediate variety, and there is no sepsis, almost 65% patient go for open PSARP. Banaras Hindu University is one of the center in India who is the master in this particular surgery. And if there is a sick children in an intermediate ARM, then 5% of our patients go for neonatal PSARP, delayed PSARP, while still 30% patients undergo a lateral colostomy. Similarly, in high anorectal malformation, almost 50% patient undergo OSLAR by either of the two techniques which I mentioned before. Almost 100% of deflating cloaca we do with OSLAR, one-stage laparoscopic anorectoplasty without doing a colostomy. But in emergency, still 40% of our patients require colostomy, while other 60% patients undergo one-stage anorectoplasty. This is what I shared with you all based on our experience of so many years. And I know this is a controversial thing, but this theme was for discussion.
Vikesh, thank you very much. And as you promised, you have put in a new paradigm, I think, about how to manage PSARP or how to manage children with anorectal malformations without subjecting them to colostomy and truly using minimal access surgery. Without doubt, it is provoking and it is thought-provoking. And I'm sure there would be a lot of questions from people. I think there are quite a few students and also some senior members who are on the chat group, on the call, and I would hope that people would discuss about whatever it is that you have said. I will start off by putting up what is there on the chat people have asked, and then we can go on to face-to-face. So what age do you perform that you already covered? Dr. Roy Chaudhary says, how do you preoperatively diagnose a rectovestibular versus rectoprostatic fistula? I guess he's talking about primary cases.
Yes, it's a very good question, but most of the time, like a good invertogram helps us to diagnose a rectobulbar fistula if that gas level is reaching right below, right up to the eye line, then this is definitely a rectobulbar fistula. But it has happened in our experience that we have taken patient for limited PSARP and turned out to be a case of rectoprostatic fistula. But most of the times, a good cross-table invertogram with good gaseous distance, especially in cases presenting late to us, they have good aeration. So you can diagnose that, but we have used ultrasound in few of our cases, but we didn't find it useful because in emergency, so much of ultrasound expertise is not available. Second, very good question you asked is about how do anesthesia cooperate in newborn distended anorectal malformation. This was a challenge for us in our initial experience. We were not having a very good pediatric anesthesiologist. So, but in 2000, almost 14 or 15, we got one anesthesiologist dedicated to pediatric surgery department, appointed under National Health Mission under RBSC scheme. And that guy, we got it trained in South in Kanchi Kamkoti under Dr. Ramesh, and he mastered literally like doing a lot of neonatal procedures, a good anesthesia care. So obviously, if you don't have good anesthesia, then it becomes impossible for you to perform such a difficult, procedure in newborn. One thing you asked is how to avoid intraperitoneal leak in C-costume, but we haven't come across that because a distended bowel, when it is stuck to the abdominal wall, usually it doesn't leak, it doesn't go inside, and in 7 days you do a pull through. After that, child almost stops passing through C-costomy and passes through paranus. So that it becomes like a fistula and gradually it narrows down.
How exactly do you perform the cecostomy? What is the technique?
So we keep the patient in the supine position under general anesthesia, and small incision we give in the right iliac fossa a little bit laterally, and we identify the cecum, lift it with the Babcock, give a small nick and not a big nick, and just hitch the muscle with the colonic muscle with the rectus, 4 stitches all around, and then a mucosa to skin and anastomosis. We don't make it like everted one, like we normally do in colostomy.
So do you keep a catheter through them?
No, sir. No catheter. And we give
And
washes after 3-4 days to evacuate the distal rectum, and then we go for a contrast study in these cases where we have done a blowhole cecostomy. After 5 days, we go for a contrast study to ascertain the level of the fistula, and then we go for pull-through delayed primary in the same admission.
prolapse is not a problem?
In few cases, we encountered prolapse, sir. But 2 of the cases I remember we had to take a purse string suture. After we took purse string suture, it closed down, sir. So prolapse is a problem, especially when the child is hungry and cries a lot, and it starts prolapsing. So in 2 of the cases I remember we took a purse string suture, but gradually they closed down. This Ankur has asked one good question about modified LAR. And here the perineal incision is just below the coccyx, maybe like 2 centimeter in an infant. And it doesn't cross the sphincter complex. So muscle complex is not divided at all. Only the levator above the pivorectalis in the midline is divided. And rectum is assessed through, and it becomes very easy once you have mobilized the rectum laparoscopically.
So you will turn the baby.
Yes, sir. This is one disadvantage of this procedure, that you have to turn the baby. Dr. Satish Kumar has given a comment that sigmoid colon unit will sit in the right iliac fossa, especially with dilated colon. How to differentiate from cecum? It may become, yes, right, sir. It does happen at times that you create a colostomy somewhere else. You want to do a sigmoid, you want to do a transverse colostomy, you do a sigmoid colostomy. But that is something which is learned with experience. And usually, like if you are careful, you go very laterally, you identify the reflections, peritoneal reflections, identify the appendix to label it as cecum, then usually the problem should not occur. But obviously, yes, you're right, it can happen.
Does somebody want to come online and speak? Just unmute yourself and come online if you need to discuss or ask some questions. We have little time.
Can I come in, sir? This is Ankur from SGPJ.
Yeah, please come in. Please come in. Yeah. Can start. Yeah.
Yeah, nice presentation, sir. So what I was asking, sir, is like what we do is we don't first give the sagittal incision and then turn the child from prone to supine during LAR. Just in the lithotomy position, first place your ports and mobilize the rectum till the fistula, repair the fistula and divide the rectum. And then in the same lithotomy position, give us small sagittal incision, divide the muscle complex, and then under laparoscopic vision, you put a port from outside. So I think many people do that. What are your comments on that?
This is a proper conventional laparoscopic, pure laparoscopic pull-through. I spoke about modified approach only for those cases where the fistula is low down, like you have taken a case for laparoscopy, and there's a rectobulbar fistula, which you are not able to dissect completely from above.
Okay.
So those cases, you can like defer it there, close the ports, take out the ports after rectal mobilization, and then turn the patient and adopt a modified LAMSAR. So I think you missed my early part of the presentation where I showed a picture where there is a diverticulum, big diverticulum developing. So I used to face this problem in rectobulbar fistula. That's why we modified it for only those cases where there is rectobulbar fistula and not able to go up to the narrowest portion of the fistula from above. We are not very sure about it, then we add that combined approach.
So in prosthetic or bladder neck, you will do the same, sir. Like
right. In prosthetic bladder neck, you don't need a posterior.
Classical LAR. Yeah. Okay.
Yes.
Thank you.
Thank you.
Subhashish, do you want to come online and discuss? I think you were asking about some urinary catheter and things. Are you?
Yes.
I think Dr. Rauchadari has asked, what if you fail to pass a urinary catheter during neonatal LAR?
There are various options available. Like normally, small maneuver which I have personally developed is like you press on the perineum. As such, there is no anus. So you press on the perineum up to the prostate and then guide your catheter. Second option is like you can use a foot catheter. Third option is like you can put in a cystoscope and put a catheter. So there are various options available, but usually like pressing it like from perineum a little bit, abutting at the posterior urethra, because there is always an angle in the urethra, especially in cases of anorectal malformation, that urethra gets angulated a little bit. So once you divide the fistula, that angle goes away. So even if like catheter is not feasible, then you can divide the fistula and then put the catheter. Then it goes straight, because that angle which was there because of the fistula gets ameliorated. Or you can put in a cystoscope and put in a catheter. So there are various ways of doing that. Even if you don't put a catheter and you have done a good pull through, then it doesn't cause any problem as such.
Thank you, Vikesh. I think very nice presentation and very exciting. And I couldn't stop without asking you, because this is what I dread. It's a dreaded fear that not able to pass a catheter and injuring the urethra, especially in a newborn. And especially as you are encouraging the youngsters to do more and more such operations in one go in the neonatal stage, either PSARP or LARP. So my fear is that if one is not sure about the anatomy and fails to catheterize or face any difficulty, there is a great danger of damaging the urethra. And we do see urethral damage post PSARP, post LARP, and then it becomes a very messy thing to handle. These children live a long time on an SPC and becomes very difficult to reconstruct. So it's just a matter of concern, and one should be careful. And as you mentioned, all the maneuvers to pass the catheter, one should know about those maneuvers. But if one fails to do all those, to me, the safest thing would be still to just go lost to me and wait for the child to grow up and do a better cystoscopy with the bigger cystoscope. Thank you.
So what you see here is actually like I have been doing it for almost 18 years or 16 years. So you can directly, you can't go home and adopt each and everything out of this. Only objective of this talk was a little out of the box thinking based on the geographical challenges. You have to modify the approach towards management of any particular patient. So our geographical challenges were like late presentation, then patient dying out of colostomy diarrhea at home, not in the hospital. Hospital care we can improve. So that made us like think about reducing the colostomy rate in our particular unit. So this is just an idea which is I want to basically
your idea is very well taken.
Your mind.
Yeah, you delivered it very nicely, and it is very well taken. And one has to make advancement. And what Pena described, the 3-stage procedure, now almost 3 decades ago. So the new generation has to find newer ways and smarter ways and quicker ways to do it with less invasive things, which should always be acceptable.
Thank you, sir, for your comments, sir.
One other question. I saw you in a lot of the videos you were using harmonics and things. So what ports do you use? 5 mm ports all around, or do you prefer?
5, obviously, sir. When harmonic is there, then that port has to be 5 mm, sir.
So usually you use, even in the neonate, you use 3 5 mm ports, or what do you do?
Neonates we use like mostly cautery, but if we are using harmonic, then we have to put a 5 mm port. Other are like 5 mm telescope and 3 mm working port. And Maryland we insert through 3 mm, and another like a right-sided working port for harmonic is 5 mm.
Okay.
But port size doesn't matter to us much because, sir, we don't put ports, sir. We do by direct stab techniques. Sir. We give a stab incision, put in a mosquito, and directly put the instruments. So for us, like initial part we do with the 3 mm. If we want to switch over to 5 mm, we just dilate a little bit more and put the harmonic inside.
Okay.
So if you're putting port, then you have to change the port.
Okay.
Vikesh. Hi, Satish here.
Yes, hi Satish.
Hi. Nice innovative technique. About the time technique, you said you pass a cannula right from behind, below, to decompress the colon.
Yeah. So we direct the cannula towards the sacral promontory.
Yeah. And do you do a muscle mapping before that, muscle stimulator to pass the needle?
That is not really very important. It can be done, but because you are just putting on a needle, you are not doing any incision around that. So your objective is just that needle should hit the dilated rectum.
It will definitely hit the rectum, isn't it?
Yes.
That the length is enough. Yeah.
This is what we have experienced.
Yeah. And what about the track? Will it interfere with the muscles? Muscle sphincter, Not really. That track will be small enough to.
I think it's a small enough track. Should not be causing any problem.
Okay. Thank you. Nice innovative technique.
Any other questions? Any other comments? Please feel free to either raise your hand or unmute yourself and talk. Any of the youngsters, do you want to ask any questions? Any comments? I think there is a significant geographical variation, because I think you have about 850 cases in about 10 years. Is that the time frame? That is about 80 cases a year.
Almost 80 cases a year, sir. Even
yeah,
more
so,
than that at times.
Yeah, so that's a very large number, and for reasons that are unknown, I think south of India we don't see so many. Yeah.
Sir, reason is we have very less number of pediatric surgeons in this particular region, central India. So
Okay.
I always encourage, like, there is lot of potential for youngsters to flourish in these areas, and they should come. Like in private practice, there are very few pediatric surgeons in a city which is harboring almost 30 lakh population. So in fact, at times we have to say no to the patients.
Yeah.
So
Yeah.
I encourage youngsters, they should go back to their own place, districts, and develop pediatric surgery, and they will prosper like anything. And a lot of respect comes from the society back in return. So this is the point, sir. Why we get many cases? Because no one else is doing. So from all the districts around Jabalpur, it comes into the medical college. Yes.
If any other questions? If not, I think Vikesh, we will wind up. I think
Yes.
it has been an excellent talk, and I think the lesson that we have to take is that you're in practice, you are thinking about your patients, you have identified problems, and you have tried to find solutions for those problems. You have tried things, some have worked, some have not worked, you have modified and you have moved on. Clearly identifying what the problems are and then following it through with trying to find solutions. And not only that, also writing and publishing about those solutions, so that it is peer reviewed and there is some verification of the work that is being done. So I think that is a very, very nice circle that you have gone through, and I think it is something that is worth emulating for all of us. The other thing that I would like to highlight is you are doing all this on a background of a large experience. So as you mentioned, you have not just come off training and then you're going and doing all these things. You have built up a large experience which has allowed you to do these things. So my suggestion is, if those people who want to venture into doing these things probably should reach out, maybe go and spend some time with you, see a couple of cases being done before venturing out and trying to experiment. Because I think the point that Subhashish made, you have a very narrow margin of safety in these newborns. And so my request would be that if youngsters wanting to try it out should reach out to you, and I'm sure you'll be happy to have them over, to see what exactly is going on and how you do these techniques. So with these, we will close this session. Vikesh, thank you very much. It's been a very, very interesting and very, very nice presentation and a wonderful journey. Thank you very much, and thank you to all the participants who attended.
Thank you, everyone, for patient listening. Thank you.
Thank you, and good night. Good night.
Good night, sir. Thank you.